I think we should start because most of the people are around, and if anyone is coming, they can join us later. Is that okay with everyone?
Yes, please.
Yes, we can start now, please.
Okay. Assalamu alaikum, everyone. Can everyone hear me?
Yes, we can hear you at Saidu Teaching Hospital.
Right. So first of all, thank you so much, everyone, for joining us today. I'm very grateful to all of you for taking out time out of your busy schedules and join us here. Particularly massive thanks to all the amazing organizers for making this session possible and help us to reach out to all of you. So I'm hosting this session today. My name is Dr. Zahabia Salim. I'm a graduate of Khyber Medical College, and at the moment I'm a hematology registrar in the Imperial College. My co-host for the day for this session is Dr. Sidra Shahid, again a KM site. She's a psychiatry registrar here. I'm very grateful to Dr. Khwaja Nizamuddin for taking out time and be our presenter for the day. He will be talking to us about the management of electrolyte emergencies. Dr. Khwaja Nizamuddin is an endocrinology registrar. At the moment, he's working in the Royal Infirmary of Edinburgh. For those of you who are joining us for the first time, may I take a couple of minutes just to give you a brief introduction of our project. So basically, Medics United, I can say it's a brainchild of my class fellows and myself. So we are graduates of Khyber Medical College class of 2007. And for the past 13 years, we have been working all across the globe, including Pakistan, in different ranges of specialties. And a few months ago, we thought that maybe now is the time that we should make a platform where we can share the experiences and particularly the positive things which we have learned over the years by working in different healthcare systems, and use this opportunity not to share our experiences, but at the same time, use this platform to learn from all of the amazing people like yourselves who have excellent clinical skills and knowledge back home. So basically our project, Medics United, it's a multi-faceted project, which would have quite a few wings. So basically in the upcoming months, we would be introducing along with these academic sessions, there would be some training sessions, which mainly would be focusing on the life support courses, like advanced life support, basic life support, trauma life support, pediatric life support. Similarly, we are hoping to start some coaching sessions where we would be focusing on the training of exams like PLAB, USMLE, postgraduate exams, including the membership exams of the Royal College. And we would also be focusing on some clinical activities in the form of telemedicine, like e-consults and teleclinics. We thought that starting from an academic side of the thing would be a good idea, as good clinical knowledge, as we all would agree, forms the basic of sound and good medical practice. So you all must be wondering that in the era of information technology, where anyone just with the click of a button can access all the amazing lectures from the professors of the renowned universities internationally. So what is different which we are offering through our sessions? So basically the idea behind these academic sessions or the online tutorials was to bring up a platform for the doctors back home, which is interactive, and at the same time, something which is more practically oriented, to provide a very practical approach towards the management of the emergencies, particularly for our junior doctors who are working in the casualties and who are managing the acutely unwell patients in the wards, with something which is validated according to the international standard practice guidelines, concise and easy to follow, and at the same time is in line with the local facilities, and not just talking about all the fancy and complicated investigations, half of which might not be available, especially in the remote setups. And most of these would be more about the clinical skills and good clinical acumen rather than any fancy or complicated investigations. So this is basically the background of our academic side of the things, as well as overall the project Medics United. I would also like to take this opportunity to ask all of you that we would warmly welcome if any of you want to join us in this project. We would very much appreciate all your skills, your knowledge, and your experience. So whether it is in the form of any suggestions or feedbacks, or if you want to be an active member of our team. Well, we are all the same team and we are together in it. But if you want to be a more active member of our team, please let us know through our emails, which would be shared in the upcoming slides. And also most of our organizers have our email IDs. So please feel free to contact us, and we would be very happy to have you with us on our team. So I would not take any longer on talking, because we have a very informative session coming up, to which even I'm very much looking forward to. So I would pass it on to Dr. Khwaja Nizamuddin. Over to you, Dr. Nizamuddin.
Thank you. Thanks, Zabia. So I'll try to share my screen first. I hope you can see the first slide.
Yes, we can.
Thank you. Thanks for the brief introduction. I am Saidu Sharif. I'm one of the diabetes endocrine registrar based in the Royal Infirmary, Edinburgh, here in the UK. And today I'm going to talk about diagnosis and management of electrolyte emergencies, which is, Zabia rightly mentioned, is something very common, and it's something very basic. That's what we are planning to target through these sessions. We see it on a daily routine in our clinical practice, especially in the hospital setups. Our objectives of the talk will include the clinical aspects of the electrolyte emergencies or electrolyte abnormalities. We are not going to talk about physiological aspect of it, which is more related to basic sciences. As a trainee in the hospital now, or as doctors, we should focus more on the clinical aspect of this problem, which should help our patient and our clinical management. We will talk about a different situation that can happen when you find someone with electrolyte abnormality, especially if it is an emergency situation. And also we'll talk about the problem that was the reason or the cause to this situation and its impact on the patient. Important thing is to prioritize your management steps. What is important and what should be done first, and then going further in terms of management plan stepwise. I will mention in the end again, but we are planning to make some sort of guidelines, which will be a handy tool available through different online resources, for example, Facebook or our website, and it can be readily available to our doctors. Like they will be for different areas and clinical work, including the electrolyte emergencies we will cover in those guidelines. So it should be available hopefully in the near future, inshallah. And we will discuss a few cases and we will learn through those cases. I hope you're already been told by our kind coordinators, if you can go to your browsers on your mobile phone or devices and type in slido.com. This is a website where I'll be using this one for making this session a bit more interactive by asking a few questions. The answers will be all anonymized, but I'll really appreciate if you can open the slido.com on your web browsers, and it will be asking for a code on the homepage. The code is 45553, which should allow you to access the questions that I put on this website. Right, so first, let's talk about sodium. The reason I chose sodium as a first electrolyte to discuss is it involves a bit of thinking process, especially when it comes to a problem like hyponatremia. So it doesn't affect heart as such directly as compared to other electrolytes. But yes, it can be problematic for the patient. It can be problematic for the doctors as well, because it can be pretty tricky, basically, to find out the reason for someone who's been hyponatremic. Hyponatremia is straightforward. There is one slide in the end, which we'll discuss the hyponatremia through that slide, but we'll chat more about hyponatremia. So hyponatremia is low sodium, when the sodium is less than 135 millimole per liter. If you have got units in milliequivalent, it will be less than 135 milliequivalent per liter. It could be a bit different in different lab setups, but you will have a reference written on your lab results for the patient. The reason it is important, if someone comes into the hospital, for example, other problems like liver cirrhosis, MI, pulmonary hypertension, chronic kidney disease, and you find them being hyponatremic, then it would suggest that the patient has got worse prognosis if unless treated otherwise. So you should take it seriously if you find someone being hyponatremic, especially if they are severely hyponatremic. Then that should be treated promptly. Again, it has got direct impact on the nervous system in the form of, it can, especially if there is a rapid shift in sodium happens, then it can cause cerebral edema or demyelination, which we are already aware of from our basic sciences and all from medical school. But this is something that can happen. It's not very common. It's rare, but it still happens. And the worry is if it happens, then it will be a permanent damage. It's classified in different ways. The most common classification, which is clinically relevant as well, is based on the volume status. So if we are seeing someone with hyponatremia, it's always important to check the volume status. By that, I mean if the patient is dehydrated or if they are fluid overloaded or if they are euvolemic. And this will help in management plan, which we'll discuss in the next few slides. And then again, another way of classifying hyponatremia is if the patient is symptomatic or asymptomatic. And talking about symptoms, it could range from something like headache to feeling nauseous or vomiting, a confusion, low glycemic scale or coma, or even seizures. So a patient can present in a variety of fashion depending on how severe the hyponatremia is or how quickly the shift has happened. A few things that we already have studied in our physiology and the medical schools, but I thought I will revise them. There are some basic rules when we talk about hyponatremia. And it involves, first thing we need to remind ourselves that the plasma osmolarity is mainly defined by the antidiuretic hormone, which is secreted by the posterior pituitary gland and our thirst drive. For example, if someone is drinking loads of water, more than, for example, 5 liters a day, you will expect their serum osmolarity to go low. And at the same time, the antidiuretic hormone will kick in and it will antidiurese basically, and it will, the antidiuretic hormone will shut down and it will make the person to diurese more, which means it will help with the serum osmolarity to go up as they lose more water when they have low ADH. And it happens the other way around. If someone is drinking very small amount of fluid, they need to conserve their water. So their pituitary gland will release more ADH and they will retain water by the kidneys. And then through this fashion, the urinary osmolarity is basically will adjust or will tailor based on this ADH activity to make your serum osmolarity in the normal range, to keep it in the normal range. And it affects the sodium as well. It affects other electrolytes, but as sodium is one of the main electrolyte that is present in the extracellular fluid, like in serum, then that is, it gives big shifts or big changes to the sodium that we see in our patients, and subsequently can have impact on our patient, as we discussed in the previous slides. If you see someone with who is euvolemic, then always think of that, yes, the patient looks euvolemic, but they will have total body water is more than what someone who is truly euvolemic could be. And this is in the context of someone with low sodium. So if someone has got low sodium, but they look euvolemic, you always think they have gotten extra water, total water, as compared to their sodium level. Some of the causes that could be related to could cause hyponatremia. Some of the reasons: SIDH, syndrome of inappropriate antidiuretic hormone, which itself happens in due to multiple reasons. Again, it can range from like infection. It can happen secondary to cancers, fractures, and trauma. So there are a lot of reasons that can cause SIDH. How do we diagnose it? We will discuss it in the next few slides again. Other common reasons that you might find in your patients is being hypothyroid. Someone, if they are drinking loads, as I said, then that can cause what we call psychogenic polydipsia, and that can drop the sodium. Ecstasy use, for which you have to do drug screening in these particular patients. And bare pneumonia is more of a problem in the Western population or Western culture, when people are more dependent on beer, particularly, which has got low solutes. So they basically build up their water content, and they don't get much of proteins or other salts. They don't eat much. They will just rely mainly on beer, and it will drop. They will further drop their sodium levels. And endocrine problems like glucocorticoid deficiency, for example, Addison's, can cause hyponatremia as well. So, right, let's go to our Slido. If you can open the browsers, and as I said, if you've already typed in slido.com and the code 45553, you should be able to see my first question. So it is about a 40-year-old lady who is admitted with cough and shortness of breath. Sodium is 122 on admission. She is asymptomatic and she looks euvolemic. Urine output picks up to 300 ml an hour for consecutive 4 hours. So she has got 300 ml an hour urine output for almost 4 hours now. The urine osmolarity is back, and it is 240 with urine, serum osmolarity is 240 with urine osmolarity of 180 and urinary sodium of 58. What do you do next? I'll give you half a minute to a minute time to answer this question. We will discuss the osmolarities and how to diagnose in the next few slides. So this question is a bit unfair if I'm putting it now before talking about osmolarities, but I think better we should just discuss the question first and then go to further management or diagnostic steps. Okay, so I think we should move forward. I'll show you the correct answer. It's to recheck sodium level. So we will discuss it in the next few slides about basically what happens if someone who has got a relatively low serum osmolarity and urine osmolarity more than 100 with a urine sodium of more than 30 or 40, with possible underlying infection, as in this lady, you can find she's having cough, being short of breath, and we don't have any other signs of infection as such. But if you can think of infection or long-term like COPD or asthma, which all can cause SIDH, which is the most likely diagnosis here, then you find and the patient is hyponatremic with that. So as I said earlier, if someone looks euvolemic, that means that the patient has intravascularly, they have got more fluid on board. And she's trying to get rid of that fluid. That's why she's polyuric. So you start basically seeing this patient diuresing to get rid of the extra water to correct their sodium. And you should make sure you recheck the sodium again before doing any further intervention. One of the reasons for rechecking the sodium is to confirm the diagnosis. Second, most important reason is to make sure that the sodium is not shifting very quickly, which could cause cerebral damage, or as we discussed earlier. And if it is happening too quickly, then you can give desmopressin or you can intervene accordingly, but almost always you have to involve the specialist in this sort of situation. So the workup initially is in any other clinical situation, history very important. This will give you clues what is happening, what could be the underlying etiology. Physical examination mainly focused on their volume status, as we discussed earlier. And next step is to check plasma and urinary osmolarity. The first step is to check plasma osmolarity. If you find plasma osmolarity less than 275 millismol per kilogram, we call it hypotonic hyponatremia. You go to third step, which I will discuss in the next slide. But if the plasma osmolarity is more than 275, then it is pseudohyponatremia, which could be due to other issues like being hypertriglyceridemic, having paraprotein, and for example, hyperglycemic. So it's not sort of a true hypoglycemia, hyponatremia. It's more related to the other agents that is either interfering with the lab result. You have to correct the other problems like their triglycerides, their glucose. You deal with the paraprotein, and it should improve the sodium itself. You don't need to intervene or do anything for the sodium particularly, apart from treating the other problems. If someone has a sodium level, plasma osmolality level of less than 275, then the next step is you ask for urinary osmolality. If the urinary osmolality is less than 100, this could be the reason for having the hyponatremia. And the history will tell you if someone is polydipsic, for example. It will suggest if someone has received a lot of IV fluids, or if there is increased oral sodium intake. If the urinary osmolality is more than 100, then at the same time, you have already asked for urinary sodium as well while you're asking for urinary osmolality, and hopefully you should have that in hand as well. So if the urinary sodium is less than 30, some centers indicate it is 40 or 30, irrespective of what your local reference range is. If it is less than 30, you think of heart failure, liver failure, nephrotic syndrome if you find them being hypervolemic. If they are hypovolemic, it could be GI losses, third space loss, or previous diuretic use. So again, here, the history and the other, your examination will help you with the diagnosis, along with the results that you have got back from the plasma osmolality, urinary osmolality, and the urinary sodium. On the other hand, if you find the urinary sodium more than 30, then you have already asked in your history if the patient was on diuretic. That answers your question. But if the patient is not been on diuretic, again, you look into the volume status. You have examined the patient. If they are again hypovolemic, if the extracellular fluid is contracted, then it could be due to vomiting. It could be due to adrenal failure, or adrenal salt wasting, or cerebral salt wasting syndrome, which can happen secondary to head traumas or surgery. If the extracellular fluid is normal, as we said, and euvolemic, then, and that is basically normal, mean clinical examination, you find it as normal, then it is SIDH. It could be secondary adrenal insufficiency or hypothyroidism. So this chart or this flow sheet will help you where we are, and it won't be as strict as you see it in theory. It can be challenging, but at least it gives you the guidance. And the foremost important thing is to know the fluid status of the patient, the history of the patient, to find out how much is being given in terms of IV fluids, or how much urine output has happened, and that eventually helps you in getting the right diagnosis. So other investigations, you think about relevant lab work, and by relevant lab work, I mean, as we discussed, and the causes, you might need to do thyroid function test, which could cause hyponatremia, for example. You will need to do a short synectin test or a cortisol level, modern cortisol level, to find if someone is hypoadrenal. If you are suspecting any drug abuse like ecstasy use, then you will need to do some drug screening, and that will help with your diagnostic process again. The treatment is treat the cause. If there is any cause that you find, like as we mentioned in the previous slides, if it is heart failure, liver failure, if it is Edison's crisis or hypothyroid, you treat the underlying cause and the sodium should start correcting. If it is SIDH, the treatment is fluid restriction, and fluid restriction depends on how much the person normally drinks. So fluid restriction could be 800 ml for one person, while it could be like 1500 ml for another one. As long as you are monitoring your sodium level, depending on how low the sodium is, it could be as frequent as 12 hourly, 6 hourly, or 24 hourly, depending on what are the resources available and how low the sodium is, and where the patient is in the hospital setup. For example, in intensive care or HDU, if they are symptomatic, you will need to monitor it more frequently than someone who is on a ward with a sodium level of, for example, 130. You can check it like every 24 to 48 hours, depending on your resources available. And you also monitor their fluid balance. As I said, you strictly watch their urine output, and anything that is being given IV or oral, that should be recorded on a chart. And that can help in a situation as we had in our question, like the lady who was very polyuric, diuresing quite a lot. If that is happening and your sodium is improving very quickly, then you might need to intervene at that situation to slow down the sodium improvement, sodium correction. If someone is symptomatic hyponatremia is happening in someone, then you will have different guidelines locally, but you give hypertonic saline. We normally use 1.8% saline, which is the hypertonic saline, 300 ml over 30 minutes. It could be a different strength in your setup, but you go with your local guidelines. And whatever guideline you are following, the recommendation is you should aim for correction up to 5 millimole with any single intervention. For example, if you give 300 ml of hypertonic saline, you should be expecting the sodium to improve by 5 millimole. If that doesn't happen and the patient is still symptomatic, you go on with another intervention, like giving another lot of 300 ml hypertonic saline. And you should aim for a correction of 10 millimole, maximum 10 millimole correction in the first 24 hours. And subsequently only 8 millimole after that over course of 24 hours. And this is to minimize the cerebral damage that can happen with the shift in sodium levels. Next is hypernatremia. As I said, it's pretty simple. If you see high sodium level in someone, almost always think of dehydration. One condition I can think of is hyperosmolar hyperglycemic state, someone with type 2 diabetes who is dry, possibly having infection or sepsis with kidney damage, and you find their sodium very high. The important bit here is always think of, you rehydrate the patient. That is very important in the first step. But you might find the sodium being stuck at a certain level, and you might need to think about the choice of fluid that you are giving to the patient. For example, you might think of giving them half saline or even dextrose if the sodium is not moving too much while you're giving lots of fluids to the patient. So that is one thing that I thought you should think about if you're treating your patient with being hypernatremic and very dry. Next is potassium to talk about. The reason potassium is on a second is it's, first, like hyperkalemia, we already know that you will have it on your reference range being more than 5.5 is hyperkalemia, and if it is more than 6.5, it is severe hyperkalemia. But the reason I'm discussing hyperkalemia next is it's a very common electrolyte abnormality that you see in your clinical practice, and it's very common associated with cardiac arrest as well. And again, bear in mind that if someone is become acutely hyperkalemic, then it is more likely to cause life-threatening arrhythmia, and you should take it very seriously, as compared to chronic hyperkalemia, where the heart get used to the high potassium level. Some of the causes listed here. I won't go through all the details of every cause to hyperkalemia, but you might find someone in renal failure being hyperkalemic. Certain drugs, you should always ask for drug history, look for the patient drugs. Again, a very common reason. Tissue breakdown, for example, someone who is involved in very heavy exercises or having a long lie with fall with long lie, with a high CK level and high potassium, and certain metabolic problems like DKA, Addison's disease, again, can cause hyperkalemia. And patients who, renal patients who are already prone to become hyperkalemic, and if they are eating a lot of high potassium content diet, then they're already prone to hyperkalemia, and you might find them in crisis situation as well. And you could find hyperkalemia and for reasons like the sample was sitting for a long time before it could be processed, or it was a difficult phlebotomy, which means you have to repeat the sample again. As I said, it's the commonest problem that causes cardiac arrhythmias and cardiac deaths. So I thought better we should look into the ECG changes that we could find at a patient being hyperkalemic. So the changes that you can find is either flattened or absent P waves, as you can see here in this strip. You will find ST segment depression. You will find, or you could find tall tented peaked T waves. Another finding could be widened QRS complexes. And a few other ECG findings you can find as a first degree heart block, ventricular tachycardia or bradycardias, and cardiac arrest. Let's go back to our Slido questions. And this is about a 65-year-old patient with diabetic nephropathy and a renal unit, heart failure. Heart rate is 125 beat per minute and complains of reduced urinary output. You do some blood tests and it shows sodium very high, potassium 6.7, again high, urea is 130 and creatinine 3.4. the patient has got renal failure and he has got kidney damage. Looking to these results, they are again high, both of them. What's the most appropriate next step? Again, I'll give you half a minute to a minute time to answer this question. As I said earlier, you can access these questions through your mobile phones by typing slido.com and entering the code as written on the screen here. Okay. Okay, we are seeing some more answers here. Good. Right, so I'll show you the right answer. And we will discuss it in the next few slides. So that's the proper treatment of hyperkalemia. We'll discuss that answer in the next slide. So the hyperkalemia, if you find someone, there are a few basic things that you need to think of, especially if it is severe hyperkalemia with ECG changes. You always think of cardiac protection to prevent imminent cardiac arrest situation. You think of shifting the potassium into the cells by giving insulin and dextrose. And you think of removing potassium from the body. And by that, I mean, you probably will need to dialyze the patient, discuss with the renal team, and you subsequently monitor the potassium concentration because it can go up again. And you think about what is the reason for the hyperkalemia and start thinking of treating or correcting that problem. For example, if it is drug, taking off the drug. If it is renal failure, making sure the renal guys knows about the patient and there is a plan for further dialysis if required. So this treatment is more classified based on the severity of the hyperkalemia along with ECG changes or without ECG changes. If someone is mildly hyperkalemic with a potassium of 5.5 to 5.9, you almost always, in every hyperkalemia, you think of the cause, you remove the cause, you avoid the cause, and that should help with the potassium to improve, and you recheck the potassium probably in the next 24 hours. If it is moderate without any ECG changes, you think of shifting the potassium into the cells by giving them insulin, 10 units, which will be a quick-acting insulin like Ectrapid, NovaRapid, Apidra, or whatever is available is a quick-acting insulin. And you give it along with a 25-gram glucose. The reason for giving glucose is to avoid hypoglycemia. The main agent is, helping agent is insulin, and it should be given over 15 to 30 minutes. You will be expecting it to work for about 4 to 6 hours in total, with its maximal effect in about 30 to 60 minutes. In severe hyperkalemia, without any ECG changes, again, you give glucose insulin as above, and you think of removing potassium from the body, like considering dialysis. Most of the cases, you don't need to dialyze patient, but yes, you will need in some cases, especially if you are giving repeated glucose potassium infusion and it is not helping with the high potassium levels. If it is severe hyperkalemia with ECG changes, very clear ECG changes, you always seek expert help. By that I mean, you might need to involve HDU or ITU to put the patient under a cardiac monitor, and you might, or even CCU, depending on what is the local setup like. And you will need to involve the renal physicians to consider the patient for dialysis. You always do cardiac protection, as it was in our question, one of the option in the question. It is done through calcium gluconate, 10 ml, 10%, or 2 to 5 minutes. Some suggest to give over 10 minutes. It won't make much difference. You can give it over 10 minutes And that's easy to remember, 10, 10, and 10 then. You think of shifting the potassium into the cell by giving them glucose and insulin and fusion, and you remove potassium from the body, is said considering dialysis. If you're giving someone calcium gluconate, always make sure you give it through a big bore Venflon or a long line, for example, because it can extravasate and it can cause local tissue damage. And if when you're giving insulin and glucose, as I said, the insulin is a quick-acting insulin, but it stays in the body or in the system for up to 6 hours. You consider or you make a plan for making sure you're checking the glucose, because the patient can become hypoglycemic afterwards, and you have to correct the glucose levels. Hypokalemia is when a potassium is less than 3.5. It is severe if the potassium is less than 2.5. With any electrolyte, when it is low, most of the electrolytes, when they are low, especially potassium and magnesium, you consider, you think of GI losses in the form of diarrhea and vomiting. Again, drugs is another reason, renal losses in the form of advanced renal problems like renal tubular acidosis or diabetes insipidus. Endocrine problems like Cushing's or hyperaldosteronism, metabolic alkalosis, and magnesium depletion is another reason for hypokalemia. Magnesium depletion is again important in the situation where you find someone being hypokalemic, you're treating and it is not improving, then you ask for magnesium level as well, and it could be the magnesium that needs correcting, and that's why the potassium is a bit resistant to be treated. Once you correct the magnesium, the potassium will improve as well. It's again arrhythmogenic. So let's find ECG finding with the hypokalemia. You will find U waves. It's called U waves, not because it looks like U, but it's after T. So PQRST and then U. It's upward deflection. You find T wave flattening or inversion. You may find ST depression, as you see here in V3. And you will find prolongation of the QT or QV, which is U and T are basically they're combined or joined. So you find the QT or QU prolongation, which can subsequently lead to further arrhythmias. If someone has got a cardiac history, for example, atrial fibrillation, and they are on digoxin, and you find them being hypokalemic, you should be more cautious because they are more arrhythmogenic, and these patients are particularly prone to get arrhythmias. So you should promptly treat it, depending on how low it is. You will treat it either oral or IV. And again, hypokalemia can cause cardiac arrest. The treatment mainly is gradual replacement. It is oral if it is something that is like mild hypokalemia, but if it is severe, like less than 2.7, some guidelines suggest less than 2.7, you go for IV replacement, and IV replacement can be given as a KCl 20 millimole or 40 millimole, and you can give it with normal saline or dextrose, for example, a liter bag over 6 hours or 10 hours or 12 hours, and you recheck the potassium afterwards. In emergency situation, the maximum that you can give is 20 millimole per hour IV. If someone has got unstable arrhythmia with some ECG findings and hypokalemic, and you are worried that they might go to imminent cardiac arrest, then the maximum that you could give is 2 millimole per minute for 10 minutes, and then again 10 millimole over up to 10 minutes time. And if you are doing this intervention, you always put the patient under a cardiac monitor. So they should be in a CCU or HDU ITU environment. Next is calcium. Hypercalcemia is when calcium level is more than 2.80 millimole per liter. It's further categorized into 3 different categories depending on how high the calcium level is. And the features that you will find, as you could remember from the medical schools, Moen, Crohn's, and Stones, and they will be having abdominal pain, constipation, they will have mood problems, they might be suffering from depression, for example, confusion, or coma in very severe cases, and they will have renal stones. They could have pancreatitis. So it's a wide variety of features you might find in someone who is hypercalcemic. 90% of the reason for hypercalcemia is either primary hyperparathyroidism or malignancy, but there are some other causes that are important to remember. and no, you might find in your patient, which are listed here. You will know most of the causes or these reasons. I won't go through every one of them, but the common things are common, so you always think about the common causes first, and almost always in any electrolyte problem, think of drugs. Where here you can see diuretics or lithium and hypercalcemia. The investigation that you should do once you find someone with high calcium is ask for serum calcium level, but always ask for adjusted for albumin. Don't rely on just simple calcium level, always ask for adjusted albumin. The labs will do it itself, but if it doesn't, then you ask them to do the adjusted for calcium level. Ask for parathyroid hormone levels, phosphate. The patient might be dry, dehydrated. You do urea and electrolytes. They could be in the hypervitaminosis state, like you ask for vitamin D. And if it is coming from the bone, you always ask for alk-phos as well. And depending on the other etiologies, like in the previous slide, if it is drug related, for example, you can do lithium levels if it is available. You can potentially do your investigations can be tailored more to any particular malignancy that can causes hypercalcemia. Could be cause hypercalcemia. So you will tailor, or your alternative investigation, you'll go through their route. For example, imaging you can do for a patient whom you are suspecting to be having underlying malignancy causing this problem. Okay, Slido again, question 3 is about a 40-year-old lady who is known to have breast cancer with bone metastasis. Again, you do some blood tests and you find sodium a bit high, potassium again high, adjusted calcium level is 3.90, which is again high, very high. Urea is raised to 60. What is the best next step? I'll let a few more people to answer and then you can move forward. Okay. So the correct answer I'll show is rehydrate the patient who is having severe hypercalcemia. And we will discuss it in the next slide again. So management of hypercalcemia, you always rehydrate the patient first. And you might need up to 6 liters over 24 hours. But at the same time, be mindful about a patient who is frail, elderly, who is probably have in a renal shutdown, or who might have heart problem like heart failure. So you monitor them very closely in terms of their urine output. And if you are suspecting fluid overload, then you will need some loop diuretic to get rid of the extra fluid while giving them fluids to correct their hypercalcemia. The loop diuretic itself won't correct the calcium level. It's the fluid that is correcting it, but that's more of an adjunct to the fluid to help with the complication that could happen while giving lots of fluids to a patient. And the patient might need renal dialysis and severe renal failure. And once and only once you rehydrate the patient, you think about giving bisphosphonates afterwards. A few things to consider while you're giving bisphosphonate, that maximal effect will happen in 2 to 4 days time. You won't be expecting the bisphosphonate to work in the next 24 hours or 48 hours. So if someone's calcium is stuck and you have already given fluids, you're given bisphosphonate, it's still a bit high, you wait and watch unless it is going in the wrong direction. You don't give a second dose. And again, you consider dose reduction and renal impairment, and it can cause severe hypocalcemia, especially if someone is vitamin D deficient or has suppressed PTH level. Hypocalcemia is calcium level less than 2.10, and severe hypocalcemia is when it's less than 1.90. The presentation could be in the form of perioral or digital paresthesias. It could be tetany or carpopedal spasm, laryngospasm, seizures, or these couple of signs, Strauss signs or Chvostek sign that we have studied in our medical school that you can elicit in these patients. ECG changes with hypocalcemia could be prolongation of the QT interval. There will be T-wave inversion. You might find heart block in these patients, and you might find cardiac arrest in severe hypocalcemic situation. In the hypocalcemia. The causes again is iatrogenic, which could be due to hypoparathyroidism secondary to parathyroidectomy. For example, if someone has got primary hyperparathyroidism, their parathyroid gland is taken out, they become hypocalcemic afterwards. Even with thyroidectomy, you might find people becoming hypocalcemic, and you'll find low PTH. Their parathyroid gland might still be intact, but this is a phenomenon what we call parathyroid gland stunning. So you'll find low calcium. Magnesium deficiency, very important. Always ask for magnesium if you see someone with low calcium, because the magnesium is required for a release of the parathyroid hormone from the parathyroid gland, and it you'll need to correct the magnesium basically to correct the calcium, and this could be due to itself due to, for example, someone is a long-standing PPIs. Someone with severe vitamin D deficiency, they'll have high PTH, low calcium. Renal failure, again, very high PTH, low calcium. You'll find cytotoxic drugs and a few other causes as listed here. It seems we lost Saidu for a while. Sorry, I'm not on the main screen, but I have just admitted them again. I hope they are able to hear us. Hypocalcemia investigations include the same as the hypercalcemia. The couple of different things that you need to think of is you consider ionized calcium, especially in an acutely unwell patient. The ionized calcium is a more true marker of the hypocalcemia. And you always ask for magnesium, as I said in the previous slide. The treatment is replacement again. It could be replaced in the form of calcium gluconate, 10 to 20 mLs, and 5% dextrose, for example, as a bolus. And then afterwards, you give IV infusion, and you give it. You can give a liter over 12 hours and recheck the calcium afterwards. And the rate you can adjust in between 25 to 100 ml an hour, depending on how quickly the calcium is correcting. This should be done under a cardiac monitor again, should be done in HDU environment. And you will consider concomitant or along with the IV, you give oral supplements as well, for example, in the form of Sandocal. You treat the underlying cause, for example, vitamin D deficiency, you give vitamin D or magnesium, you correct the magnesium while you are correcting the calcium at the same time. You might need to give active vitamin D metabolite in post-operative patient. And by post-operative, I mean post-parathyroidectomy patient, basically. And you monitor calcium response, especially if you are giving someone vitamin D, which will help with the calcium absorption through the gut. And if someone is, they can become hypercalcemic afterwards. So you still watch the calcium level even once they normalizes. For the next week or couple of weeks, you might need to consider rechecking the calcium level to avoid the hypercalcemia to happen. Last one is magnesium. Hypomagnesemia is when a magnesium level is less than 0.6. It can happen with GI losses, polyuria, malabsorption syndromes like shortcut syndrome or inflammation of the bowel, and alcoholism. The ECG changes could range from, again, prolonged PR or QT interval, ST depression, T-wave inversion, or increased QRS duration. Important thing to remember about hypomagnesemia is you might find someone in this sort of rhythm we call torsade de pointes, which is basically a polymorphic VT. The importance is if someone is in this rhythm, they are going to, it can convert to a ventricular fibrillation and a cardiac arrest, and patient can die in this sort of rhythm, from not particularly from this rhythm itself, but it can further lead to a cardiac arrest situation. So you always treat it urgently. And the treatment will be, again, magnesium replacement in the form of IV magnesium sulfate, 2 gram You can give over 15 minutes if someone is symptomatic or if someone is having including seizures. If you find the torsade dew point is on the monitor or on the CG strip, you give it more quickly, the 2 gram magnesium. You might need to repeat the 2 gram again and again. You might require 4 to 6 grams of magnesium to correct that rhythm and stabilize the myocardium, depending on how low the magnesium is. Hypermagnesemia is not pretty common in the clinical practice, and it is, if it is mildly raised, it's not worrying. You just recheck the magnesium after some time. You don't intervene, but it can happen in renal failure, and it could be iatrogenic again by giving too much magnesium to the patient. The ECG finding is more or less similar to the hypermagnesemia with IV block and T-wave peaking here. And again, patient can go to cardiac arrest in extreme situation. As I said, you always treat it if it is very high, like magnesium more than 1.75. It can cause cardiac instability, so you stabilize the myocardium by giving calcium carbonate. It can cause apnea or respiratory arrest. So you always think of ventilatory support in these particular patients. And if it is very resistant, you might think of hemodialysis for these patients to get rid of the extra magnesium. There is a term they use, saline diuresis. I've never used in our clinical practice. But the idea is basically you give them saline infusion and you diurese them at the same time and you get rid of the extra magnesium that way. But as I said, it's not something that is very common in the clinical practice, and especially the severe hypermagnesemia. You might find with very mildly raised high magnesium and you don't do anything for that. Right, so this last question, I have bored you a lot with electrolytes, which is a sort of a dry topic. I'm aware of that. So this last question is not a medical question, it's more a non-medical, just to refresh our mind a bit. You might be asked to join a quiz. On your Slido pages, you can join the quiz. As I said, it's not a medical question, it's just for to refresh ourselves. So once you join it, we'll go to the, I think I can go to the next page. I don't know how to pronounce his name. I think there are probably 30 or probably more than that alphabets in this name. And this is the name of our train station. And the question is, where is this train station located? If you heard about.
Nizam, are we allowed to use Google?
No, not at all. I know you're on your mobile screens, very easy to. Well, I think it will be pretty difficult and challenging if you are even typing this name. I'm going to show the answer by that time. Yep, it is Wales. With the prize. This is not a sort of a mad question. This is real. You can see the name on that board. It's a small town in the west coast of Wales. I don't know how to pronounce the name, as I said, and I have no idea why you would give a name that long to a place or to a train station. Probably just to make it more familiar, and we discuss it in things like as we did today. I did my initial training in Wales, and this is again a picture from Wales. When I see my pictures from Wales, it's a very beautiful, it's North Wales, it's a very beautiful place. But it reminds me of my early training, and it reminds me of the problems and the challenges that I was facing during my early training, including electrolyte problems, as we discussed today, which could be pretty daunting as a junior doctor when you're dealing with a patient with severe electrolyte abnormality, and you know that the patient is gonna go to trouble if you don't do anything. I think it is important as a junior doctor to know that there are guidelines and there are protocols available you can find. And as I said, we will try, and we are going to make some guidelines that will be available on the website and also on the Facebook page, which will be readily available to the doctors. They can access and they can consult through that to treat their patient appropriately. And the important thing is to recognize the problem and to prioritize the management steps. For example, in hyperkalemia, you're not going to, in severe hyperkalemia, you're not going to rush in giving salbutamol, which I didn't discuss at all in my talk, because it doesn't do much with the hyperkalemia, but you will be consider treating it with the stabilizing the cardiac rhythm first. That is something that will kill the patient rather than trying to correct the potassium in the first instance. So hopefully we'll make the guidelines or the protocol that will be available, and I hope that will be helpful for all of us. Again, thank you, and I'll open to the questions panel. If there are any questions, you can send it through the chat box. I'm happy to answer that. Thank you. Thanks a lot.
Okay. Taking over from Nizam. Thank you so much, Nizam, for such an informative session. Thank you, everybody, for listening and for your patience. Just a couple of things before we end up our session. Feedback forms. Dr. Zabia has already sent the link for the feedback forms. We would really appreciate if you can kindly complete these feedback forms at this stage when we are in our infancy stage. These feedback forms are for us are really important to help us build our session according to your needs. Another thing which Dr. Zabia mentioned in the beginning, that anybody who would like to join us in these sessions are most welcome. And the idea behind this is to learn from each other. We are not here to teach, but we are here to learn from you guys, from your clinical experience. And we know that you are all very experienced as well. Anything that you would like in the future session that you would like to for us to add in the future session, that are more than welcome. So please let us know. And the last thing, is there any possibility of changing the timing of the session from next time to 1 p.m. Because of the change in timing, difference of the timing in here? So if there is any possibility, whether that could be allowed because of the timing in auditorium and those kind of logistics. So please let us know. Before I finish, any questions from anyone or even from my colleague, Nizam, Zabia, anything that they would like to add in the end?
Thank you.
I think that's pretty much everything.
All right. Thank you so much, everybody. It was lovely having you all. Have a very good day. Thank you. Bye-bye. Allah
Thank
Hafiz.
you. Allah Hafiz.
Bye.